Well, good morning and good afternoon. This is Dr. David Willis. I'm here at CSSP and welcoming you to our webinar on advancing a family-centered community health system. We're thrilled that you've joined us, and we're thrilled about all the interest that we have with us today. A little bit about CSSP. We're an anti-racist organization that is committed to the well-being of children, youth, and families. We have a community focus. We have a strong anti-racist intersectional frame, and we're keenly aware of the challenge of this moment in time about the triple crises of not only the pandemic, but also the economic challenges for families and the issues of racism, police brutality. We believe strongly in reimagining the future and early childhood systems, and we're excited today to be able to talk about the family-centered community health home. I'm Dr. David Willis, a senior fellow at the Center for the Study of Social Policy, and I'm thrilled to welcome my co-presenters, which are Ms. Molly Day, who is a colleague of mine in Portland. She's a member of the CSSP EC Link network. She directs the family-funded initiative in Portland of Early Learning Multnomah, which is led by a group of parents and partners for healthcare systems to build comprehensive early care and education systems. Also joined by Dr. Matt Biel, who's the Vice Chair and Chief of the Division of Child and Adolescent Psychiatry at Georgetown University. He co-directs the Early Childhood Innovation Network, citywide effort to improve the developmental outcome for children and families in Washington, D.C. A good colleague and friend working also within focusing on early relational health advancement. And then Shadi Houshyar, who is a senior associate at the Center for the Study of Social Policy. She's focused on equity-driven policies to support young children and families with a primary focus: child health trauma, toxic stress, and adverse childhood experiences. She has expertise in child welfare policy and is currently supporting states in planning the implementation of Family First prevention services. And then my dear friend Kay Johnson. For the past 35 years, Kay Johnson is nationally recognized for her work in maternal child health. She's an advocate, a researcher, and a consultant. Her work at Children's Defense Fund, March of Dimes, George Washington University, and her own consultation work have really helped shape the direction of maternal child health and Medicaid policy since 1984. And I'm delighted that all four of my co-presenters are with me today and for the future for this discussion. So I'll be discussing the model of advancing a family-centered community health system. We'll then have discussants from our communities and the co-panelists we mentioned, and then an opportunity for Q&A. Please feel free to chat in the Zoom, as also ask questions as you choose. So the work of my growth and awareness of early childhood systems began with ECCS building work that first began with the HRSA grants in 2003. Each state had allocated monies to focus on system building, and the original flower, as demonstrated, captured the importance of trying to create the partnerships between interrelated and interdependent agencies and organizations representing physical and mental health, social services, families and caregivers, and early childhood education, all of which trying to build a seamless care for children from birth to kindergarten entry. That work was incredibly complicated and grew not only about building collective impact efforts, but really the effort to recognize the alignment of efforts that not only in state level policy, but also in place-based effort, a challenge and an effort that then transformed into the early childhood comprehensive systems impact program that currently was a bit more targeted towards 13 communities and focused on improving the developmental well-being of a population focus of a group of kids. When I was at HRSA, there was also the interest that was cross-departmental, focused on creating joint policy efforts to create an alignment between the child health system policy and early childhood systems work. We recognized that it was really important to try to create alignment between child health sector and communities towards realizing a vision as noted here, that all children should meet optimum health and developmental milestones as they enter school, that requires strong supports for the nurturing and positive relationships around children and families, and that it's all about supporting the context of the local communities. That work was built on the science, and it was about aligning efforts across sectors in order to do so. Recently, CMMI released 7-year grants that created the integrated care for kids, and our colleagues, Charlie Bruner, Kay Johnson, and an advisory panel generated the ink marks, which has really pulled together what can be transformative for the child health sector, partnering with the community towards realizing the integrated care for kids model for population health and improved population well-being. And what has been articulated is building the sense of the future of the expanded medical home that's much more connected to communities, building beyond medical home and the systems and structures we've had for children with special health care need with care coordination and case management, but expanding ever further to coordinate the medical home with communities focused on perhaps team-based care models like Healthy Steps, Project Dulce, or other approaches with integrated behavioral health, and the linking, coordinating, and efforts in alignment with communities themselves. We know too that the huge number of young children coming to school are struggling with social emotional well-being, if not what later becomes a growing struggle of mental health or lost developmental capacities. Research has shown that children's social emotional development is vital for school readiness, and it's a key building block for cognitive development and learning in the very early ages. Pediatric well child visits provide that opportunity to really support parents and to nurture children's social emotional well-being. So in 2017, several leading national foundations came together and created the Pediatric Supporting Parents Initiative that looked at some of the evidence-based models of delivery of social emotional well-being practices in the medical home. The CSSP and NICHQ went through a process of studying 13 of the most frequent and important models by interviewing families and the providers to look at common practices. What came forth was a recognition of the importance of nurturing parents' competency and confidence as a common practice to improve social emotional well-being. They also noted as a common practice the importance of connecting families to additional supports in the community to address stressors and other challenges, and the importance of thinking about the care team of the medical home and the infrastructure itself and the culture that made possible the supportive families in terms of moving this work forward. Yet, there are many constraints to advancing social emotional well-being in the medical home, not the least of which is time, money, and resources, but also the complexity of transforming the pediatric team for readiness, not only in their knowledge, but also their equity and their community engagement and their awareness of community. This area was ripe, and the recommendations that came from that work were clear about broadening national leadership for this systems change, with equity and race being explicitly a part of that work. Also, that we recognize the importance of supporting pediatric primary care team building and linking and partnering with community in a readiness of blending the high-performing medical home with the communities in the efforts. And of course, all of that has to be with recognizing that systemic racial barriers have to be eliminated if we're going to really make change in terms of the impact and partnering with families. This has been ever more acute in our awareness from the work of the Parent Leadership Network at EC Link that who came together and actually wrote a manifesto from a family's perspective of how they can better work with communities. The preamble of the manifesto, I think, says it all: to ensure that all children have equitable outcomes in education, health, and life We must view engaging parents and developing their leadership as mission critical. The ability to engage families into meaningful early childhood systems change has been articulated with these 5 commitments for change. Intentionally challenge racism within the system, embracing parent leadership as co-members in the development of change, prioritizing resources that help support parents in that work, thinking about creating parent pathways of parents into systems and community development, and maximizing equitable outcomes using data and CQI-like processes. Another parallel group body of work has been the work about advancing early relational health, which embraces the science that really makes visible that the relational context of building social emotional capacity requires attention to those first relational experiences that all young children and parents create. We call that the early relational health space, the foundational relationships that build these capacities, all of which advance physical health, development, social well-being, and resiliency. We believe that's a paradigm shift that focuses all things we do, cross-sector, on supporting the earliest relationships to improve and develop well-being. All of this is complex work, and it's far beyond simply collective impact. The interdependence of every one of these elements of systems change are intertwined and interact with one another. So not just policies and practices and resources, but the relationships that are present, but most of all the power dynamics, especially of connecting with parents, and also the mental models of equity, the mental models of a relational frame. All of these elements together have to come together in terms of moving an agenda forward now. By all we know, these various threads generate what we can call a family-centered community health system that we're articulating today. And we view that as an organization of people, institutions, and resources in a specific geographical area that can deliver equitable healthcare, health influencing services that respond to the unique needs of all families that are being served. Now, we have articulated and developed 6 fundamental elements that describe this work. Each of the elements are about building early childhood systems that have been in development over time. And but they've often been isolated, and we're proposing within this family-centered community health system the various elements that we're going to articulate in a second come together in terms of realizing improved outcomes. Now is the time to do this work together. So here's the beginning of the first 6 elements. One is a focus on a place-based approach for achieving population health with disaggregated data that informs local decision-making. This would mean that we would target and define a geographical local community to address neighborhood and population health. We would wish to see longitudinal and integrated data across health, early care and education system, community-based effort, and defining a set of core indicators. Some of this work's already moving. We're seeing it in Oregon, we're seeing it in Illinois, we're seeing it in North Carolina. We're aware that there are often anchor organizations and local communities, like within the All Children Thrive Network or in Cincinnati Children's or others, that have really operationalized this element as part of a family-centered community health system. The second element we want to raise up is a local coordinated early childhood system that works collectively to be anti-racist and to dismantle structural inequalities. We can no longer be complacent about the role of racism in terms of outcomes. Disparities, of course, are generated by racist policy that have to be attended to. But in order to move a system of care, we have to think about long-term leadership within a community that reflects those of the community itself. We have to include data analyses that reveal these disparities that can put action and develop active actions to make change. We have to be thinking about sustainable and flexible funding, a broadening a diverse workforce that helps support families, that engages families, and the role of leadership that families can play in governance structures. A third element that's really important to include is an element of a family-centered community health system is, as we discussed, a high-performing medical home, bringing the health system that is the platform of touching all families into team-based care models that align and partner with families, then link to communities, becomes really an essential element. Within that has to be a relational health focus and an expanding, if not a relational health workforce of community health workers or doulas or family navigators and the like that help to serve the coordination of medical home and supports for families. There has to be strong connection between the child health care and early childhood systems, family-centered, just not child-centered, all of which with including fair coordination and a focus, of course, within the Strengthening Families and Protective Families Network. The fourth element is that element of parent leadership and that networks that of parent leadership that hold programs, services, and community systems accountable. The importance of engaging parents as partners and leaders in early childhood services and policies is really essential, much like we're seeing with the Early Childhood Parent Leadership Network, the role they play and the number of the growing parent leadership tables that are partnering in systems change is really striking. It's important to elevate the parent voice in all these sectors and to work together towards dismantling any structures that would contribute to disparities, implicit bias, or the distrust of systems of support. The fifth element are those strategies that support building those foundational relationships that support improved life course outcomes as we focus on an early relational health frame. The expansion of promotion activities and interventions have to be based on the centrality of early relationships that promote that foundational relationship outcome. We're working now within some early child, the EC Link communities that have identified themselves being really interested in advancing an all-in relational health frame. We've seen that work focused also as within the work we're beginning within the Reach on a Read network to expand the child health sector's focus on a relational health promotion effort. All of that strategy is focusing on that prenatal to first 1,000-day relational intensity, all of which is within a frame that beyond adversity, one can support the positive experiences relationally to improve health outcomes, if not to break some of the generational challenges. So, did I miss number 6? Oops, that one. And then the other element is number 6, is creating vibrant and robust family and community-led networks that support positive experiences for families and children. The effort to strengthen formal and informal local family networks of support are really valuable, much like we hear about in Bridgeport, where the Brigade of Grandmothers and the elevation of the churches and the neighborhoods and local supports have strong impacts to build a robust network of positive supports around families and communities in neighborhoods that work in partnership with public health and other more traditional support services. This element, we believe, likewise is very important. So how do we move toward next steps? To move forward, this effort will require building on frameworks and leadership that already exist, that communities are already using. It really would require engaging the health providers, the health systems, in terms of broadening that experience of the high-performing medical home. It's opportunities to engage with Medicaid, Title V, and early childhood systems leaders to support these elements in building towards building an integrated family centered community health system. One could engage local parent and early childhood leaders about that focus on community factors and these root causes of disparities that are racist driven, but by surrounding and supporting and working collaboratively, we can try to move this work together. It's about expanding on longitudinal data capacities and building on top of what data capacities already exist and helping to make that data ever more visible to use data for purposes of improvement. And to be thinking about these agendas being longer term agendas, not 1 or 2 year efforts, 5, 7, if not even 10-year efforts. Of course, financing has to be a part of this effort. And certainly braiding and blending of federal, state, and local funding streams is possible, again, by vision and by leadership and by partnership. CSSP's blueprint for leveraging Medicaid and CHIP to finance change is a resource that helps articulate opportunities within Medicaid transformation. And the most recent report that Kay and I put out about leveraging opportunities between Title V and Medicaid for promoting social emotional development also provides opportunities and others, along with, of course, the philanthropic community to help move this forward. So why now? All of these fundamental elements for advancing a family-centered community health system actually do exist today. Each of these elements have been developed over the last decade, but more in isolation, and can be brought together into this a larger effort of imagining and operationalizing system change. The social justice and equity movement requires structural revisions within the guidance of families at all tables in local communities. All of these new efforts can advance prenatal care and early relational health training, foundational relationships, and the well-being of families that are required for this sense of an all-in cross-community strategy. It is the interdependence of these elements, when aligned and coordinated, where we think the real change exists. The integrating of data capacities will allow systems to be better implemented, tested, and revised as needed. So we think the opportunity is now to really reimagine, build better systems to address the current crisis of the triple crisis that's in front of us, and imagine how we can move these elements forward into a better service delivery system for next generation efforts for families. So thank you for my chance of bringing this model to you, and I'd like to turn it to Matt Biel, who can talk to us as to what this strategy could mean from his experience within the Early Childhood Innovation Network. So Matt, can I turn to you?
Thanks so much, David. Really appreciate the opportunity to be with you all today, to have a chance to speak to our experiences in DC, and in particular to speak to how useful we are finding this framework on family-centered systems from CSSP to be for our work here in DC. So in just a few minutes, I'm hoping to just describe a bit of how we're trying to do that crosswalk between work that's happening on the ground here in our network and this coordinating function that CSSP is pulling together in such an inspiring way, because we're finding it to be highly relevant and actionable. So David, are you advancing slides for me?
Yes, I am.
Oh, super. Thanks so much. Again, my name is Matt Biel. I'm a child and family psychiatrist. I'm at Georgetown. I run our division of child psychiatry, and I also have the great privilege of co-directing the Early Childhood Innovation Network. It's a network that we established in 2016, almost exactly 5 years ago. And it's a network that joins Children's National, our hospital, MedStar Georgetown, and over a dozen community partner organizations. And the idea of this network is to be informed by developmental neuroscience and to implement under local conditions with local input, local partnership, and local priorities, the clinical and learning system implications of that developmental science. We want our interventions that we develop and test and disseminate to be multi-generational and to be relational in every aspect. And we want to be integrating and enhancing existing services, existing organizations doing great work in the community, and using our hopefully the power and the good of our institutions and of our network to enhance the impact that's happening already on the ground. So this is sort of how we entered into the space about 5 years ago. The co-director with me of the network is Lee Beers, who's a pediatrician at Children's National and is the president-elect of the American Academy of Pediatrics. So she's got a terrific platform as well for advancing the work that David has been leading so many of us through. Next slide, please, David. So we've, from the outset, really tried to have an explicit and sustained focus on engagement with partners. And our partners are parents as well as parent and family serving organizations. So we're building and expanding partnerships. We're engaging our partners in a process of innovation, implementation, evaluation, iteration, rapid cycle improvement. And we're explicitly focusing on equity, on anti-racism and inclusion in all of our work. We have launched a number of pilots and have really emphasized promoting equity and emphasizing shared leadership across those pilots, and then looking at how we best catalyze cross-system change. These have been sort of our what we hope to be our engines of change and of coalition building across the city. Next slide, please. So in the first, 2016 was our planning year. We've really had pilots underway for close to 4 years now. And those have included a DC version of Healthy Steps, early childhood mental health consultation in preschool and pre-K settings, trauma-informed parenting supports that built around a mindfulness-based intervention, perinatal mental health screening and interventions, a number of well-being interventions oriented towards providers, both health providers and education providers, supporting infant and toddler social emotional learning in early childhood education settings, a number of place-based health supports for families with young children. In the last year and a half or so, we've been developing multi-generational mental health care that's embedded in early learning centers. That's work that we're really excited about and are working to expand quickly. And then we've used parent cafes extensively as a way to galvanize and build the buy-in and engagement from parent leaders and natural leaders in communities. So these are about, I guess this is 9 of about 12 or so pilots that we've launched at various stages of gestation across our network. And next slide, please. This is just a brief slide, and this, unfortunately, this is out of date, but just briefly indicating that we've had, at this point, about 4,000 children and families served. We had about 2,000 reached through our Healthy Steps programs. We're receiving ongoing support from Healthy Steps. About 1,000 kids who've been in settings receiving early childhood mental health consultation. And you'll see some of the other numbers here. I think the less important is the specific numbers than to indicate that we're on a rapid trajectory of growth in terms of the footprint and the reach of our various pilot studies. Next slide, please, David. So the question that we asked ourselves as we've tried to get up to speed with this work that CSSP is leading is, can our network help to create a family-centered community health system in DC? And as David laid out those 6 steps, I'll just try to talk briefly through the crosswalk that we've been doing that connects our work to the CSSP model. Thanks, David. So can our network help to create a family-centered community health system in DC? As David noted, the first step was a place-based approach to population health using disaggregated data. So we've worked closely with our State Department of Education around creating an integrated data system. This is come out of the PDG grant that was awarded to DC. DC already now for 4 years running has collected EDI data at a population level, which can be very useful. And we've been fortunate enough to be involved in a place-based initiative focusing on 2 neighborhood clusters within DC's Ward 8, which is the southeasternmost ward of DC, in which we were able to access disaggregated data from the DC Department of Health from previous citywide needs assessments to figure out which neighborhoods had highest needs in the early childhood space, and how to understand the strengths and vulnerabilities of families living in those neighborhoods in order to design a place-based initiative that was really focused, as I'll say in a few minutes, on community health workers working with young families. Next slide, please. David's second item was a local coordinated early childhood system working to dismantle structural inequities and racism. So again, the place-based initiatives that were funded locally, based partly on EDI data collection, I think were a really important way at beginning to understand how these structural inequities are playing out in DC for young families. Much of our network pilots have been oriented around the Frontiers of Innovation model out of Jack Shonkoff's center at Harvard, which really is, as many of you know, focuses on what are the moderators predicting specific outcomes for early childhood interventions, and how can we figure out what works for whom and why. And that's a very compelling stance to take around this intervention development work that we're doing. We are, in all of our needs assessments, whenever possible, we're mapping families and interventions to place within the city. We extensively subcontract and partner with family-run and community-based partners in DC, entirely Black-run organizations that are focused for decades now on addressing and undoing some of the inequities that are so built into the way that our city runs. And those partnerships have been central to the, I think, the success and the velocity of some of our pilots. We have an intentional focus on increasing workforce capacity across our pilots. I can come back to that, speak to that a bit more in a few minutes. Again, our core partners in family advocacy and community organizing spaces have been really, really critical partners. We've worked with them around the relational health screen. I'm sorry, the relational health standpoint. I'll come back to the relational health screen, but the relational health way of thinking and that orientation, which I think has been very compelling for these organizations. And they've taught us some of the basic building blocks around community organizing, which has really inspired some of our approaches, particularly around advocacy. And we're also really focusing on building a formal parent network to guide decision-making beyond individual pilots. All of our pilots have parent advocacy entities, but a larger formal parent network to guide our overall strategy really seems critical. Next slide, please.
Yep.
Thank you. So David pointed out that we need high-performing medical homes that support families and connected community supports. So as I mentioned, we are implementing Healthy Steps in 2 Children's Hospital large community-based primary care clinics, and we're expanding in the next few months to 2 MedStar sites. Our version of Healthy Steps includes, in addition to the Healthy Steps specialist, a family care coordinator who's a parent from the neighborhood where the clinics are located with relevant lived experience and training in healthcare navigation. That's been a really powerful addition, we think, to Healthy Steps for our families. We've had some really successful and we think hopefully long-term successful advocacy for public funding for implementation of Healthy Steps citywide. Really excited about that potential. The Family Wellbeing Program is a full-service, family-centered model of comprehensive multi-generational mental health care that's embedded in about 12 ECE settings now in DC. So we're providing mental health care for dyads, young children, and their parents in ECE settings, and with building collaboration with the Department of Health and Department of Behavioral Health and with Medicaid in the city to think about sustainability beyond grant periods for these models of multi-generational mental health care. We're doing quite a bit of multi-generational health screening and health support in pediatrics through Healthy Steps, and we're piloting use of the relational health screen tool in pediatrics through that approach. And we've been doing a lot of focus on provider well-being for the entire pediatric team in all of the sites where we're doing the Healthy Steps model. Next slide, please. Parent leadership networks to ensure system accountability is so critically important and something that we really need to continue to lean more heavily into. Our leadership team of our network, the executive team, includes the directors of several longstanding family-run health advocacy organizations here in DC. We have a family research advisory board that, again, is expanding into this larger formal parent board. We've had an intentional focus on racial equity within early childhood systems in DC, and also really importantly within our team, which has been important, difficult, and ongoing work. We've done a number of trainings as a team, including on doing racism and race forward. We initially started with a racial equity council across our team. And again, our network includes about 75 individuals. We now have, that council has evolved into a racial equity community of practice that we have team-wide, that is a monthly practice that we do as a team. We're also in the process of how we use what we're learning about community organizing to become a more effective community organizing entity as a network, because we feel like that's something that we can really contribute. Next slide, please. And David, I'll wrap up in a minute or two. Intensive, coordinated, and comprehensive services for infants, toddlers, and their families that support foundational relationships. So this is really embedded in almost all of our interventions, perinatal work, in OBGYN and in pediatrics. We've created learning communities and trainings around infant and toddler social emotional learning across a large network of early childhood education centers in DC. We're doing teacher well-being in a number of settings as well. Mindful parenting is a group-based intervention that we're expanding to additional ECE settings. It began at our Educare DC site, and now we're expanding to other sites as well. And again, the family well-being program is the multi-generational mental health program. So we're looking for lots of these coordinated embedded services. And then finally, family and community-led networks that support positive experiences for children and families. We're really excited about the ways that some of the programs that we are developing and hopefully disseminating have this community-led network sort of infrastructure at the center of them. And critical to that are these roles for community members. They've got sort of different professional titles and different projects of ours, but we have neighborhood family champions in our place-based initiative. We have parent advocates who are parents from the preschool communities that are involved in our multi-generational mental health program. And then we have family service coordinators, again, who work closely with Healthy Step specialists at our Healthy Step sites. These are all community members with outstanding people skills, with outstanding relational skills, who have a profound interest in supporting the development of these systems and have joined our teams. And we see great opportunity for this workforce role to really grow across all the work that we're doing. So I'm sorry if I took too much time. I really appreciate the opportunity to speak with this group and really look forward to hearing the other panelists' comments as well. This is my contact information. I'm very glad to hear from anyone, anytime. Thanks so much.
Spectacular, Matt. Thanks so much about making the family-centered community health system alive and the amazing work that's going on in DC. And so Molly, can I turn to you?
Absolutely. Thank you, David. Matt, it was so great to follow you. I think that the work that's happening in DC is just really inspirational. It's kind of what I want my work to be when I grow up. I think the remarks that I'm going to share with you all today are much more from the perspective of system building than service delivery, and come from a place of being very young and growing in this work. So David, let's do next slide here. I want to focus my remarks today on two of the transformational elements that David includes in his brief. And this first one, a local coordinated early childhood system that works collectively, that first part, that feels like something that's happening in many places in the country, and I'm really excited about. And it's the second part of that statement that is really transformational to dismantle structural inequities and racism. I think it's very fair to ask, is that the task of an early childhood system? Is that its job to collectively dismantle structural inequities and racism, to be an anti-racist force? And my answer is yes, that is completely our job. And what we've learned through my work with Early Learning Multnomah, which is a state-funded initiative in my county that's designed to build an early childhood system, is that we have to go at that second half of the statement just head on. What we've learned over the last 7 years has been that we cannot back our way in to thinking that the system is going to dismantle structural inequities. We've had to be upfront about that and clear about it. So I want to share with you the second little paragraph here on the slide. This is from the Already Network, and I think this is more of what David was thinking of when he thought about this work in Portland around a family-centered health system. And we've pulled together about 60 partners from across a wide variety of social services, healthcare, and education into a network that's committed to being sure that all children are ready for school. And when we did this in 2018, you can see this was our vision statement, and it's pretty clearly a statement that's written by, if not a full committee, at least a whole bunch of people. But the pieces that I want you to see in this are that this very complicated group, we had 150 people in the room, we were making a big pivot. We were moving away from the early idea that an early childhood system supports school readiness based on a child's skill set at kindergarten entry. And we were beginning to say that the responsibility is on us as the adults in the system to create an environment in which children and families thrive. And once we started to look on ourselves as the adults in the system and our responsibility, then we had to begin talking about racism. So early on in 2018, it's just when I read this, it still kind of cracks me up. We were just barely persuading like our healthcare partners that that if they were going to talk about health disparities, they were really talking about racism. Because early on, they were like, no, 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 we're not an anti-racist program, we're healthcare. And this was where we first began to make that shift. So, the other thing I wanted to say about this slide is that I picked this picture of these two kindergartners here. They were at one of our gatherings, best friends. And if you're just on the phone, they look white. One's white and one is black. And part of what's so important in focusing on an anti-racist agenda is to see what's invisible. And what's invisible with these two girls is that they're both Native American and very active in their respective tribal communities. And it just reminds me every time that I think I see clearly, but I don't always. And being able to dismantle structural inequities and racism means being real clear about what we see and what we don't see and what we need help in seeing. So David, if you'll go to the next one for me. As you scan through this, you'll see, like now in 2020, this is the work of the Already Network. It's become much more focused and upfront about work on an anti-racism perspective. And as we look at these big lifts for the network, just remember that this is a network whose backbone is a health care system, and that it has child welfare in there and education, and together we're trying to figure out how do we move in this direction. So then, let's see, moving pretty quickly. David, let's do the next one. Next slide is the second of the transformational elements I wanted to highlight. It's transformational element number 4, parent leadership networks, which we all, we love that part of our work. If you're like me, that's like the best part of the day is when you get to talk to constituents, to clients, to the community that you're helping to organize. And again, the transformational piece is the second half of that. It's these networks that hold us accountable. And you'll see from this little paragraph below that our Already network is just beginning to understand what it means to partnership with families in this. And we have a long way to go, but my other work with my early Learning Multnomah initiative, this is my leadership group here. This is a network that we created, a community of parents, very deliberately, not from white community, but from the communities that experience the greatest disparities as revealed by economic differences in our community. So it's Somali, it's Vietnamese, it's Native American, it's Latinx, and it's African American and African immigrant. Did I get them all? And this group of parent leaders really do hold my team accountable. And that's what's been super tricky, has been not only to make this group of fantastic people into a community that can have lesbians as well as devout Orthodox in it, but can also really think broadly about the well-being of communities all across the county. And the way that they hold us accountable is in this next slide. David, if you'll do that one. Is they set up guiding principles for us, for my initiative, Early Learning in Multnomah, in our very first year. We worked through all of these, and you can read them yourself, but they are really significant for the way that we make our local investments, the way that I have a staff of 5, the way that we spend our time, what we get engaged in. And just as a very small example, recently we had to come back to them last week to talk about a significant state budget cut and where were we going to take it. For us, it was $250,000. In the next 6 months, it was big. And as we worked through these guiding principles together, it led us to ask questions like, does this decision go beyond fair and equal and address power imbalance? Does it work for equity? Does it match what parents have told us they want and need? Is it parent-centered? Does it support the whole family as well as the child? Does it create family engagement? And I think that's the transformational power about having parents in leadership, is that it happens when they're able to hold us accountable and we learn how to share power and let go of power. Then that's where really exciting things can begin to happen. And anytime you're talking about power, you're talking about racism. So we judge the success of our work as based on how often do we talk about racism, how comfortable are we about it, not in terms of complacent, but skilled and intentional. And I really love this piece of work that David and the team have pulled together, and I'm really excited to see these transformational elements in it, and look forward to learning more. So thank you, David.
Thanks, Molly. There's some really wonderful comments in the chat as to how inspiring your words are. Thank you for sharing this with us. And Shadi, can I turn to you now, please, about some anti-racist?
Yes. Great. Hi, everyone. It's good to be here with you today and to share a bit about our efforts at advancing equity and anti-racist early childhood policies. I was a bit ambitious with my slides, so I'm going to move quickly. Apologies for being very fast. So at CSSP, in all our work, we lead with equity. We're guided by our anti-racist intersectional frame and are always asking the questions, how can this work dismantle racism, and how can this work shift power? So our anti-racist intersectional frame recognizes the social effects of race, and that omitting a racial analysis from any work allows racist systems, laws, and policies to continue operating within the status quo. It requires an understanding that the impact of racial oppression is not fully realized without interrogating the intersections of all forms of oppression. It calls out white supremacy and white privilege and recognizes anti-Black racism. And it questions the motivations of traditional institutions, acknowledging their role in distributing and maintaining oppression based on identity. Next slide. So our frame is very much at the core of our approach to early childhood policy. Families of color experience trauma perpetuated by historic, systemic, and institutional racism. And we have to actively work to redress these inequities and intentionally push forward policies and practices designed to right past wrongs. To effectively do this, policy solutions have to be explicitly anti-racist, acknowledging root causes of inequities, be designed to eliminate disparities and achieve equity, and provide services and supports to achieve health and well-being for children and families. So the focus of our work is on advancing anti-racist policy agenda for early childhood systems that recognizes that a range of policies are needed and critical to supporting young children and families. So we've outlined some principles that are intended to guide systems, administrators, policymakers, advocates, and other stakeholders who share a commitment to developing anti-racist early childhood policies. I was going to go into a little bit of detail, but what I'll do is just quickly go over these principles. I think many of them are well understood. So the first is you have to establish a commitment to dismantling racist policies that harm children and families. Key here is sharing this commitment with other stakeholders, and this is a place where you really have to be critical with yourself about who those stakeholders are and ensure that the families you serve are at the table and at the center of the work. So our second principle is to implement strategies that help to identify and dismantle racist policies. So child and family serving systems can help unpack how they're currently organized, how racism impacts systemic and institutional beliefs, policies, and practices, and work to actively dismantle these entrenched harms by using approaches like continuous quality improvement, institutional analysis, and race equity impact assessments, as well as trainings and anti-racist frameworks. Our third principle is ensuring that all child and family serving systems and sectors are involved, and policy solutions use a cross-sector, coordinated, collaborative approach to connect children and families to the resources and supports they need to thrive. The reason that this sort of coordination and collaboration matters is that if you don't do it, the burden sits with families. So we have to be coordinated, we have to be collaborative, because the ultimate goal is to better serve families, more work on our end, less work on theirs, to build family-centered responsive systems. The fourth principle is to prioritize family-centered, responsive, and flexible policies to better meet the needs of young children and families of color. And this is because for so long, racism drove decisions to make it intentionally difficult for families to access the services and supports that they need. So examples of ways we can do this is benefits to families through direct cash transfers, or family-centered strategies like providing services and supports in places where families already spend time. Next slide.
Oops, sorry.
That's okay. Our fifth principle is to build protective and promotive factors for children and families. So early childhood policies can focus on supporting families and building key protective and promotive factors that enable children to thrive. These are certainly at the foundation of the Strengthening Families framework and can be used to help guide systems, policy, and practice. Our sixth principle is bringing an intersectional lens to policy and practice by ensuring that programs support and affirm identity development for children of color and those who are gender diverse. We know this is critical in early development, and so early childhood policies must promote and affirm positive identity development, specifically racial identity and sexual orientation and gender identity expression for all children, and specifically young children of color. Our seventh principle, and we've heard a lot about this, is sharing power with families. So we know that barriers rooted in structural racism and biases that influence attitudes, behaviors, policies, and practices of child and family serving systems prevent many families of color from being true partners and leaders in their child's healthy development. Again, the onus is on us to effectively and truly authentically engage families as partners in all aspects of policy development and implementation. Our eighth principle is to ensure community health workers, peer advocates, promotoras, and others who are often from the community to serve with lived experience and expertise in supporting families as they navigate services are a valued and growing part of the workforce. And policies can effectively scale community health worker models and ensure that adequate funding is there to reflect and recognize the importance of these roles in child and family serving systems. And our ninth principle is to build capacity and collect meaningful data that measures what matters. The people most likely to be shortchanged by or not adequately captured or represented in available data are often the most marginalized. And there's a number of strategies that we can use in ensuring that we're disaggregating data by race, ethnicity, that we're integrating community voices into this research design processes, that we're developing resources for high quality, widely available survey data that's really looking at intersectional dimensions. And using data analysis to assess the racial impact of our work on communities served. So now, next slide. We wanted to make sure we had a chance to share with you a few examples of how the key elements of the family-centered community health system align with our anti-racist early childhood policies. I want to make the point that principles are only valuable if you're intentional on how you use them to guide your work daily in an anti-racist way and in a way that's family-centered, in a way that is defined by families and not by you. So for example, key element 1 aligns with our principle of building capacity and collecting meaningful data that measures what matters. This is clear in the family-centered community health systems model, where there's a discussion around the intentional use of data to drive change and all changes being analyzed to determine the differential impact that they may have on children and families in specific neighborhoods, racial, ethnic groups, and families with children of differing abilities. The second element aligns with our principle to establish a commitment to dismantling racist policies that harm children and families. Each of the components of the family-centered community health system must be carried out through anti-racist approaches. And there's a great discussion around working to achieve equitable outcomes that acknowledge the unequal starting places that different populations experience based on historic and structural racism. Key element 2 also aligns with our principle to implement strategies that help to identify and dismantle racist policies. So key element 3 aligns with our principle to prioritize family-centered, responsive, and flexible policies to better meet the needs of young children and families of color. So in family-centered community health systems, there's an emphasis on high-performing medical homes that link to visible, coordinated, accessible, and effective community services, bringing to the medical home the abilities to support families' needs identified through day-to-day child health care. Key element 4 aligns with our principle of sharing power with families. In family-centered community health systems, there's a focus on ensuring that systems that strive to be responsive to these unique family needs must become family-centered and shift to accommodate increased parental engagement and decision-making power. And in key elements 2, 3, 5, and 6, those all align with our principle to ensure that all child and family serving systems and sectors are involved, and policy solutions use a cross-sector, coordinated, and collaborative approach to connect children and families to the resources and supports that they need. And I wanted to mention that also, the key elements of the family-centered community health system lift up and align with our principle to ensure community health workers and others with lived experience and expertise are supporting families as they navigate services and a value and growing part of the workforce. So quick examples, but really appreciate the elements in the family-centered community health system and how they align with strategies to have anti-racist early childhood and child health systems.
Thanks so much, Shadi. And now we're in the ninth inning. We're going to go extra inning, if not a little over. And let Keg, you want to kick it out of the park and talk about?
Sure.
Your good work.
Can you hear my voice?
Good.
Okay, let's do this. Let's do the first slide. So Shadi has talked about principles particularly related to anti-racism and a lot of the things that really need to, you know, that are driving forces for policy. I'm actually going to talk about some, you know, governmental roles related to policy. Next slide, please. So I'm going to talk about Title V and Medicaid very specifically in the context of Medicaid, both Medicaid and CHIP. Most of the children who are enrolled in CHIP are in fact in Medicaid, so we like to talk about them together. And they are a really important driver for our thinking about equity in access to health care and other services. So it's more than a quarter of all U.S. children under age 18 and more than half of children of color, particularly Black, Latinx, and Native American and Alaska Native children are in the Medicaid program. And Medicaid and CHIP together cover more than 40% of the children under age 3. That's 7 million infants and toddlers. If the health coverage isn't making sense, isn't financing what children need, isn't supporting providers to deliver what children need, then clearly that's something we all need to work on. Medicaid and CHIP could be, for example, financing high-performing medical homes in the way that David described them and using an enhanced rate when they are proven to meet the criteria for high-performing medical homes. They could be reimbursing the roles that all of the other commentators have talked about for community health workers and doulas and family navigators, particularly when they're delivering prevention services. They could be using accountable care organizations, coordinated care communities, and accountable health communities to increase the breadth of services for families with young children in order to address social determinants of health and this variety of factors that lead to inequity in health outcomes. They're a mechanism we haven't yet fully leveraged. Right now, they're mostly being used for adults with chronic conditions, but Oregon and Vermont and some other places are leading the way for us on this. And they could be advancing integrated care for kids, not just the people who got funding from the Centers for Medicaid and Medicare Services under the federal grant program, but using other integrated care models that are designed to better serve young children and their family, to build these kind of systems, to build structures and payments that foster integration, not divide up and segment and silo services. Next slide, please. In the Title V program, Title V obviously is based in every state. Title V, as most of you may know, does relatively little direct service, but it is the anchor for what goes on in an array of maternal and child health programs. So virtually every Title V program is doing some work in early childhood. Many of them become the grantee, not only for early childhood comprehensive systems grants from the Federal Maternal and Child Health Bureau, but for preschool development work, for work that goes on around developmental screening. They often are the house for WIC, for prenatal care programs, for other services and support such as family planning or children with special health care needs. So they're both the anchor and they provide the glue. And the fact that they have this flexible funding and the ability to set priorities and to support a wide range of action makes them a very powerful force in this area if they should choose to be. They could, for example, continue early childhood comprehensive systems efforts and advance them toward the FCCHS. They could be funding place-based initiatives, including family and community engagement and systems building. Supporting family leadership networks. They're very often doing that for children with special health care needs, but we need to engage Title V in building family leadership networks beyond those who have children with special health care needs. Applying an equity lens to their own work to assess their own policy programs and staff, as well as that of their contractors. This is underway in Massachusetts, in Louisiana, in Illinois, and other states. In North Carolina, It's a very important way to do the work. Michigan has done it in terms of infant mortality. We just need to do it more widely and not just in isolated segments of programs. Title V can support the training of the workforce in both anti-racist and relational approaches. There's a lot of workforce development effort that goes on in Title V agencies, and some of that's related to this community workforce, such as community health workers and so on, but it also could be a role with the medical home providers. And supporting social emotional development and foundational relationships. Dr. Willis and I have done some work this year where we looked at what Title V agencies were doing, very often focused narrowly on just developmental screening, and we want that work done and we want that developmental screening done, but broadening out to think about social emotional development, screening, the responses, the strengths-based approaches, as well as elements such as social determinants of health screening and responses to that. And finally, Title V has a lot of influence over how child health data and measurement are undertaken. They could go much farther than just the small number of measures to which they're accountable for in terms of the federal government, and really think about the role of data and in driving change in community action in the way particularly that we heard Molly and Matt describe today. So that's it for me, Dave.
Spectacular. I know we're over time, and so I welcome people putting questions into the chat, which we will answer. But to finish up and to let you all go, those of you that were able to stay on, the report of the Family Center Community Health System is posted today at this URL on the website at CSSP. And I wanted you to see the members of our team. We welcome further conversations. We're going to be continuing to work on our framework. We welcome others to join us along the journey. If any of you are interested in sharing or learning with us further, please contact us. We're eager to hear from you. We're eager to continue further making visible the movement and the efforts we have around this space. So I want to thank everybody for attending today. And the slide set and the webinar will be posted on our website within this week. And so we're going to sign off, but again, I'll stay on to answer any questions that people want to pose. I want to thank my panelists and thank all of you for attending. Thanks so much. Well, I think we did pretty well.